Hello, everyone. I'm Ramnath Subbaraman. I'm an associate professor in the Department of Public Health and Community Medicine and the faculty lead for the Tufts University School of Medicine Global Health Seminar Series. I'm pleased to welcome you to this month's seminar entitled Success from the South, the Indian Rotavirus Vaccine Story. So the Global Health Seminar Series is a monthly lecture series that occurs both in person and online. And our speakers for this academic year have included Alan Cowman, who talked about novel anti-malarial medications, Mosapelli, who talked about combating HIV and COVID-19 pandemics in Botswana, Evan August, who talked about Sawubona healing circles, and Ochiewunma Akwiwu Ibe, who talked about community health systems. Next month, on April 17th, our speaker will be Indra Narayanan, who will talk about neonatal survival in India and other low and middle income countries. We're very grateful for the support of TUSM Global Health Programs under the leadership of Professor Honorine Ward and our administrator, Kim Burke, the support of the Tufts Center for Global Public Health, led by Alice Tang, and from Global Tufts, as this is an official Global Tufts Month event, and special thanks to Christine Hohenhorst for the support. To welcome this month's speaker, so actually a couple of ground rules. So for those of you online, if you can put questions in the Q&A, we'll be looking at them ahead of time. Please put them as they come to your mind because it takes a while to show up in the system. So to welcome this month's speaker, I'm now pleased to hand over the podium to Sunil Kumar, president of Tufts University. Thank you.
Thank you, Ramnath, and thanks to our speaker, Dr. Kang, for joining us. I found out it's at the end of a 3-week road trip, so I'm delighted that she's able to do this. I wanted to say two things before I turned it over to Dr. Honorine Ward to introduce our speaker. When you ask what in the concept of a university in the last 50 odd years, there's been a change. And from a place where people go to get educated to a place that tries to influence the world in a positive way, hopefully, way beyond its walls. And you can ask, what are the kinds of areas where this influence can be maximally impactful? It's very hard to think of an area that's more impactful than public health. I came from Hopkins Engineering. Hopkins Engineering had a minor achievement. It chlorinated water. You can figure out how many lives were saved because of that. There are some statistics the Hopkins PR department would make me repeat, but now that I work for a competitor, I refuse to do so. Tufts has had impact like this. We have actually eliminated a major disease, except that it wasn't in humans, but this is, I forgot the name of the disease now that affects livestock, rinderpest. Rinderpest in this veterinary school, and the story is a vaccine story. The heat stability of the rinderpest vaccine the problem was solved at Tufts Veterinary School, and we have since kept it a state secret. So we've not told anybody about it, but so I'm really speaking to the younger researchers and the students in the audience. You should aspire to save lives million at a time. That's also a slogan of a competitor, but we can steal that. And vaccines are a good way to do that. So I look forward to hearing Dr. Kang. With that, I'll turn it over to one of our own esteemed researchers who's for decades run our global health program, Dr. Honorine Ward. Over to you.
Thank you very much, President Kumar. Before I introduce our speaker, I just want to acknowledge again Global Tufts Month. We were fortunate enough to get a grant from Tufts Global Month to support this seminar. So thank you to them for their support. So I'm delighted to introduce Dr. Gagandeep Kang, affectionately known as Cherry to many of us, a distinguished leader in global health and infectious disease research, and a dear colleague of mine. Dr. Kang currently serves as the Director of Enterics, Diagnostics, Genomics, and Epidemiology in the Division of Global Health at the Bill and Melinda Gates Foundation. In this role, she leads efforts to develop new vaccines with a particular focus on understanding the challenges of oral vaccines in children. Prior to joining the Gates Foundation, Dr. Kang enjoyed a prolific career spanning 40 years at the Christian Medical College, CMC, in Vellore, and my own alma mater, where she held several significant positions, including professor of microbiology, vice principal of research, and head of the Wellcome Trust Research Laboratory and Division of Gastrointestinal Sciences. Dr. Kang is no stranger to Tufts. She was a visiting fellow in the Division of Geographic Medicine and Infectious Diseases at Tufts Medical Center many years ago, but she has subsequently been a longtime collaborator of mine and others in the audience today in NIH-funded research in enteric infectious diseases and nutrition, as well as in education and training. She has been to Tufts several times and is an adjunct professor in the Department of Public Health and Community Medicine. Her research has been instrumental in vaccine development for rotavirus and other enteric infections, contributing to significant reductions in mortality rates. Her groundbreaking contributions have earned her numerous accolades, including being the first woman from India elected as a Fellow of the Royal Society and the first Indian woman elected to Fellowship of the American Academy of Microbiology. She was recently elected as an international member of the US National Academy of Medicine. Please join me in extending a warm welcome to Dr. Kang. Welcome back to Tufts Cherry.
Hello, everyone, and thanks so much for the invitation to come to here and to talk to you about one of the very few success stories in my life. And I'm only a small part of this story. So what I'm going to be talking to you about is really rotavirus vaccines and the lessons that we've learned from these vaccines. Now, if we think about, let's start with India, right? 1.4 billion people, 25 million people born, new babies born every year. This has shrunk a bit. It used to be 27 million. We're now down to 25 million. If you think about an immunization program that needs to reach every child at least 3 times a year with vaccine, such as the rotavirus vaccine, you need 75 million doses. The rotavirus vaccine was introduced into the US in 2006. The cost of immunizing one child with rotavirus vaccines in the US, was $200. So you're talking about 75 million doses needing to be given, 25 million children needing to be immunized at a cost of $200 to immunize one child. I figured out at that time that it would take about 90% of the Indian health budget. Just one intervention. So obviously it wasn't possible. So if you need to think about access, the way things have mostly been done in India, particularly around immunization, is if we can't make the vaccine in the country, the kids are not going to get it because we make vaccines cheaply for our kids. So if we think about this question of access and equity, that's really the heart of public health. And in India, I will tell you that the exact same vaccines that US children use, made by Merck and by GSK, those vaccines became available 2006 in the US, 2008 and 2009 in India, right? So every child in India had the opportunity to get the vaccine if they could pay for it. There are 100 million people, 100 million families in India out of our 1.4 billion population that can and do pay for private healthcare. So the population that accesses private healthcare in India is actually equal to the US population. Big market for drug companies. But who do you want to see getting vaccines? I think you really want the vaccines to benefit the people that have the greatest need for those vaccines. And that's really poorer people. So, what I'm going to be talking to you about today is rotavirus disease, vaccine development, the Indian story, and what lessons it leaves for all of us. Now, rotavirus and Tufts has a veterinary school, so we'll be pleased to know that once again, vets were ahead of so-called human doctors because veterinarians had identified a long time ago that there was a virus that caused diarrhea in young of multiple species. That was called a reovirus or a duovirus. It wasn't until Ruth Bishop, the lady with the baby here, who looked down a microscope of biopsies of children with diarrhea in Australia, that she identified that these viruses were being seen in the gut of children with in whom no bacterial cause could be developed, could be identified. She called it a duovirus initially, and then subsequently it got called rotavirus because it has a nice wheel shape. And as soon as tests became available, it was clear to everyone around the world that most unexplained diarrhea in children was actually caused by this pathogen. Now, this discovery of rotavirus causing gastroenteritis in children was in 1973. And efforts to start to make a vaccine started really very early. Now, if you look at group A rotaviruses, there are multiple groups, but A is the one that affects babies the most. It is the most common cause of dehydrating gastroenteritis in children. In the US, it was over 60% of gastroenteritis before the introduction of vaccine. It's less than 5% now. In developing countries, because we have many, many causes of diarrhea, rotavirus was somewhere between 40 and 50% of gastroenteritis in children. Now, in the US, children don't die of gastroenteritis or of rotavirus because you have access to health care. Before the vaccines came in, it was estimated that in the US, approximately about 10 children might die of dehydrating gastroenteritis. And, you know, when you're talking 10, it's a lot of variability in those numbers. So essentially, hardly any child would die of this condition in the US. In other parts of the world, that's not the case. And why is that? It's because babies are small. If you're losing a lot of fluid, your chances of dehydration are much higher. And rotavirus also causes vomiting, which means that you can't give oral rehydration solution. And dehydrated babies, it's very hard to start an IV. You need a really skilled person to do the IV, which essentially means if your child cannot access skilled health care, your child is going to die in a developing country. So that's why prevention becomes really important. And it's important to understand that, you know, rotavirus affects all children. Unlike bacteria, where hygiene can make a difference, for viral gastroenteritis, hygiene makes much less of a difference. It can delay infection, but it can't really prevent it. These viruses infect with a very small infectious dose, so infections tend to be very common. And that's why we believe that prevention by vaccination is really the key to improving child survival for this infection. Now, the approaches to developing rotavirus vaccines started very early, started in the US. Shown here is Al Kapickian, the father of the first and several other rotavirus vaccines from his work at the NIH. The virus was discovered in the 1970s. Trials started with various vaccine candidates in the 1980s. There's a lot of history around how people decided what to make into a vaccine, but I'll cut that short to say that the first vaccine was licensed in 1998 in the US, following trials done in the US, and the first vaccine was made by Wyeth. Now, why would you want a vaccine for a disease that doesn't kill children? Well, because there are lots of economic costs to having a child in hospital, having a child who's ill, which is why the first vaccine wound up being tested and licensed in the US by a US company. Now, at the time that the vaccine was licensed, this is what a map of the world looked like. Now, if you just look at this map, this is diarrheal diseases, and most deaths are rotavirus deaths because it causes most of diarrhea. Where do you think the vaccine was really needed? Okay, we'll move on. Now, this was the vaccine. It was a rhesus rotavirus vaccine. So essentially monkey virus, and you put the proteins that are on human viruses on the surface of the monkey virus. So they developed this vaccine. It was absolutely fabulous, gave 95% protection against severe gastroenteritis. 1.5 million doses were given out. And then your passive adverse event reporting system, VAERS, reported an association with intussusception. Now, the interesting thing was, I'm not sure, okay, I don't know if you can see that pointer, but you can see that the intussusception was occurring in the first week after the first dose of vaccine. So when you have this time sequence, you know that there is an association between vaccination and the adverse event. The vaccine then wound up being withdrawn. The risk was proposed to be about 1 in 4,000 vaccinated children. Later, it was revised to about 1 in 11,000 vaccinated children developing intussusception following rotavirus vaccination. So with that vaccine withdrawn, there was a lot of questions that were asked. Rotavirus doesn't kill kids in the US. How about using this vaccine in developing countries where kids do die of rotavirus gastroenteritis? Intussusception doesn't kill kids in the US, but the counterbalance is intussusception could kill kids in developing countries. So how do you do the risk-benefit trade-off here? But following this disaster where the rotavirus vaccine field thought we are not going to progress for a very long time, just 8 years later, because of efforts of Merck and GSK, we actually wound up with 2 new vaccines. They needed to have much larger clinical trials, 60 or 70,000 infants in each study, with the idea that the studies should be able to detect a risk of intussusception that was at least equivalent to RotaShield. So the vaccines came out, were very rapidly approved by ACIP and other bodies. The cost, as I mentioned previously, was 200 a course, and the first GSK vaccine that came into India in the private market was about 1,800 or 1,200 per dose, depending on whether it was being bulk purchased or not. So that at the time was about $40 to $50 as an equivalent price. So much less than the US, but still unaffordable except for the very rich in India. Now, these 2 vaccines that came out had very good efficacy, 85% with Rotarix, 95% with Rotatec. They didn't show any risk of intussusception, but they were available. And they started to be marketed around the world. They were recommended by WHO, but the question was, could you afford it? Now, in India at that time, we had been doing a number of different studies, some of which I will refer to, but the most important one was to try and figure out was how much of a problem was rotavirus in India. So we established this network of laboratories around the country, the National Rotavirus Surveillance Program, and we showed that 37%, 2 out of 5 children hospitalized with diarrhea actually had rotavirus. We used the studies that we had done in the community and in the hospital to build this disease burden pyramid, which you don't often see. Most often, when you measure disease, you just measure the top 2 tiers, which is how many people are hospitalized and how many people die. Because we were working in the community and we were looking for asymptomatic infections as well as symptomatic infections, we could actually define what proportion of children were getting infected, how many of them needed outpatient care, how many needed hospitalization, and how many died. We found that 50% of all children had a rotavirus infection every year. 1 in 8 required an outpatient visit. 1 in 30 was hospitalized. And 1 in 650 children died of a rotavirus gastroenteritis. And this was an estimate for the 2011 birth cohort in India. Now, given that kind of disease burden, it was obvious we needed a vaccine, but which vaccine? Would it work? Could we afford it? So RotaShield had been produced under a license from the National Institutes of Health. And India and the US had an Indo-US vaccine action plan, which had been established in 1987 that supported rotavirus vaccine development. And it supported the development of an Indian vaccine. So when Dr. Bhan, shown here in this picture, was a young pediatrician at the All India Institute of Medical Sciences, he had identified in 1985 an outbreak of rotavirus infection in a neonatal nursery where most of the infections were asymptomatic. So there is a good story behind that, which is essentially WHO had made a new ELISA kit for rotaviruses. They distributed it to many people in many developing countries. Dr. Bhan got it and was looking for a good source of easily accessible stool. So neonates were an easy way of getting stool. He thought he was going to be testing for a negative result, that neonates without diarrhea would not have rotavirus in their stool, and found that actually he had 50% of newborns hospitalized for 3 days had rotavirus in their guts. So then he had to figure out, is this one strain, many strains? Figured out it was one strain, characterized the strain, and found that this was a persistent infection. The one thing that he did different is he followed up the kids that were discharged from the neonatal nursery and found that kids who had had that neonatal infection actually subsequently had much less severe disease due to rotavirus. So this made it then a vaccine candidate. There was a similar second neonatal strain that was identified at the Indian Institute of Science, the alma mater of your president. And they had also identified a neonatal strain that was in kids. They also followed up those kids and then showed that there was less infection and disease in the children who had had that neonatal infection. So now you had 2 potential vaccine candidates. These were taken forward under the Indo-US Vaccine Action Program. And at that time, India did not have the ability to characterize these viruses as they needed to be characterized. So they were then brought to the US. They were produced in bulk, again, technology not then available in India. And the phase 1 trial of these 2 potential vaccine candidates wound up being done in US adults. This was followed by phase 1 studies in the target populations or descending to target populations in US children. When it was shown that these vaccines were safe and could induce an immune response, they wound up being taken back to India. The technology was transferred to an Indian vaccine company that then started the development of this vaccine. So they did phase 2A studies, again showing that the vaccines were safe, that the vaccines were immunogenic. They decided on a dose of the vaccine. They dropped one of the candidates because it had a lower immune response. And then they wound up doing a phase 3 study. Now, the question is, obviously, the US had and Europe had moved faster. In 2006, you had licensed vaccines that were available that had been recommended by the WHO. Now, how do you do a placebo-controlled study in India? So this resulted in a lot of consultations with panels coordinated by the WHO that essentially said that for oral vaccines, we understand that the performance in developing countries might not be the same as in developed countries. So therefore, there is at least it's plausible to do a placebo-controlled trial in a developing country. But they said then that you had to make sure that whoever you recruited into the trial had the best possible health care. So that meant that this study that we did in Delhi, Pune, and Vellore, at a time when mobile phones were not available to the general population, every mother got a mobile phone with the phone number of the field worker and the doctor responsible for her child. We wound up paying for open heart surgeries, for hernias, for burns, but we looked after every problem that these children had for a period of 2 years when we were doing follow-up. And we wound up conducting a study that was the first phase 3 efficacy trial for a vaccine that had been manufactured and at least mostly developed in India. So this was an incredible effort. We ran a call center, took over our lives for about 4 years. But essentially, we wound up with a vaccine that's called Rotavirus. This vaccine had an efficacy of 55%, and it was licensed by the Indian regulatory authorities in 2014. Now, I showed you the data from Rotarix and Rotatech, which were 85 and 95% efficacy. So did this mean that India had produced a meh vaccine? Well, we had previously been working on community-based studies in Vellore, where we were trying to identify a correlate of protection of rotavirus. And we had found that our studies were showing, this was studies of natural infection. And in Mexico, it had been shown that if a child had 2 previous rotavirus infections, they had 100% protection against severe gastroenteritis. In fact, that had been the basis of developing oral rotavirus vaccines, right? When we tried very hard to reproduce those studies in Vellore, they didn't work. We got, after 2 infections, only 57% protection. After 3 infections, only 80% protection. So why 55% efficacy? Well, there are a lot of factors, but early exposure to infections and damaged guts can lead to lower protection when you give an antigen orally. So when we compared our data to the Mexico data, the 100% protection, we couldn't replicate that in India, no matter how hard we tried. They also said that second infections were less severe than first infections. We had not found that. We found that you had to have at least 3 prior infections before you got less severe infections. And then they had found that second infections were caused by a different G type, a different class of rotavirus. We didn't find any of those findings in India. When we took all of our data and we plugged it into modeling studies, our data from natural infections plugged into modeling studies actually showed that you would get 50% efficacy with an oral rotavirus vaccine. So if you look at the 55%, then the vaccine actually performed better than we had predicted. Had we been in a high income country, we would have got with the same vaccine 95% efficacy. So the vaccines are equivalent. The people that we give the vaccines to are not the same. So what does lower efficacy in developing countries really mean? And here I'm going to walk you through just either one of the panels. So let's take Bangladesh and Vietnam on your left-hand side. In Bangladesh, the vaccine had 46% efficacy. In Vietnam, it had 72% efficacy. But the background rates of rotavirus diarrhea in Bangladesh are 9 per 100 child years. So if you have 46% efficacy, you actually prevent 4 episodes of rotavirus diarrhea. If you look at Vietnam, Vietnam has a background rate of 2.8 episodes per 100 child years. So 72% efficacy prevents 2 episodes of rotavirus diarrhea. So even though the vaccine performs less well in Bangladesh, because the background rates of infection and disease are so much higher, you actually wind up with preventing more disease, even though you have lower efficacy. And that, I think, is very important to understand. Where are these vaccines needed? And how do you make a decision about how much disease is prevented with which vaccine? So, when you have to take a vaccine into the program, you have to persuade policymakers that the vaccine is really needed. So is there a disease burden? Is it a priority? Is it recommended by WHO? Would use of the vaccine promote equity? And we made the argument that the vaccine was a vaccine that was really meant for the poorest people in India. So making sure that we had the vaccine in the public program was going to be important. They accepted our arguments. We had certainly made the case for disease burden and for showing that the vaccine worked. Vaccine use was recommended in 2014, but just to point out, having a vaccine isn't sufficient. So the vaccine had actually been made by the company to say, we are going to be using less oral polio vaccine, so there will be freezer space within the system available. We're going to make a vaccine that fits that empty polio space in the freezer. And the vaccination program turned around and said, no chance. The vaccine was a 2.5 ml vaccine because you had both buffer and the vaccine dose. The program said, we can't deliver this. So we had to scramble to urgently do a study without buffer, show that the vaccine was equivalent, change the labeling, work with the regulators and the company for that, and then make a packaging change for a larger dose vial so that it could be introduced into the program. So decision in 2014, actual introduction took until 2016. India has 25 million people, but it took until 2019 for us to be able to make sure that every state in India was receiving this vaccine. So the second vaccine was based on an NIH strain that was developed by the Serum Institute of India. One of the problems is when you have 25 million kids to immunize, 75 million doses is a large order even for a vaccine company. And you want security, so therefore the program always asks for two vaccines so that they can trade off on prices and on security of supply. So we worked with Serum Institute of India on the testing of the next vaccine as well. This vaccine was actually tested concurrently in Niger and in India. In Niger, it had 67% efficacy. In India, about 40% efficacy. And then, when you hear stories of successes, it's always wonderful. But there were also vaccines that failed. So we worked with another company called Shanta on the same vaccine that Serum was working on. It had beautiful immunogenicity data, but when we took it into a phase 3 comparison with the Merck vaccine, the non-inferiority for this new vaccine was not established and the vaccine program was halted. There's another company called Hilleman that also had a vaccination program now using the Merck bulk, and they decided that making a heat stable vaccine did not make sense looking at how the program was progressing. So, what have I told you about? I've told you about 4 different programs in India. 2 succeeded, 2 failed, right? So, this is the way it plays out in the public health space. What did we learn from all of this? One is that vaccine introduction in India has always lagged behind the rest of the world. And I'm just showing you a comparison of the UK and India here. So measles in 1968 in the UK, 1986 in India. Between 1986 and 2009, India did not introduce any new vaccines. In 2009, we got the pentavalent vaccine, so HIB became part of the program. And the pneumococcal vaccine came into India in 2020, only when an Indian company started to make the pneumococcal vaccine. So for our birth cohort, self-reliance is the only way to go. Now I'll tell you about what India making vaccines means for the rest of the world. Well, in 2018, the Indian vaccines were pre-qualified. They became available for $1 a dose. They're now at 70 cents a dose. And last year, 74% of the poorest countries in the world, the rotavirus vaccines that they received were vaccines that were made in India. Now, this is true for Gavi, that about 60% of all of the vaccines that are bought by Gavi for the poorest countries in the world are being made in India. Why are they made in India? Because India has an internal market, which it then provides for, and then can have the capacity to expand to also provide vaccines for the world. So many more companies are now standing up in India with an idea of making more vaccines for the world. This is just an example of when vaccines have been introduced into Gavi eligible countries and Gavi non eligible countries. And essentially, what you see is that there's usually a huge lag between when vaccines are introduced. First, it goes into rich countries, then it goes into poor countries. The only places where we have seen a change in coverage has been where the vaccines have started to be made by producers in Gavi eligible countries like India that then provide it to Gavi, and then coverage rates go up very rapidly for the populations that are in Gavi countries. So I showed you this map before for diarrheal diseases for 1998, which was before the vaccine started to be used. One of the nice things about looking at maps like this is that in 1990, you can see what the pattern of deaths around the world looked like. And after the introduction of vaccines through the Gavi markets in 2019, we still have a problem, but it's not as much of a problem as it used to be. So, lessons, it takes a long time. The strain was discovered in 1985. The vaccine became available in 2014 in India. It was introduced in 2016. It takes a very large team to introduce these vaccines and to make them. It takes a lot of capacity, including from government, a lot of engagement, a lot of investment. It needs a lot of problem solving, and through all of the programs, there was a lot of help from the NIH and partners to help us work our way through this. So in India, of course, all clinical research is a challenge and safety monitoring is a challenge. So I told you the good part of the story, which is that the vaccine worked. We also had anti-vaxxers that then took us to court. So both CMC, me, the Department of Biotechnology have had the wonderful experience of going to the Delhi High Court and to the Supreme Court because we were harming Indian children. We were giving them a vaccine that had the risk of interception, even if it had not been proven in the clinical trial. So we started out to do an evaluation of the performance of the vaccines after they were introduced into the program. Just to summarize, this is what happened to disease. Vaccine coverage went up, disease went down. The seasonality of rotavirus is shown as peaks. The shrinking size of the peaks means that the vaccine is working. And then we looked for interception. I showed you that peaking that was seen after the first dose in the first week after the first dose. Here you see the first, second, and third doses, and there is nothing like that peak that is seen here. So rotavirus vaccines are working in India, they are safe, and they are effective. So I'll stop there, and I'd just like to say thank you to all the people that work with us.
Thank you so much, Dr. Kang. We've had a quiet online audience, so I'll encourage them to ask questions. But for our in-person audience, I think we can take questions now. Yes, I'll repeat the question actually on here for our online. So just to summarize, the question was about lessons for implementation of public health innovations at scale.
So I think there are two parts to this. Well, there are multiple parts to it, but I will highlight the ones that I think are most important. One is, what are you delivering? And the second is, who are you delivering it to? And have you made sure that you are setting yourself up for success? And what I find is the best way of doing that is actually to interact with the communities that are going to be recipients of the intervention, to see what is it that they want. Is it a priority for them? And if it is, what's the best way of building their confidence and their trust in whatever your intervention is?
Just to summarize the question for the online audience, it's about sort of damage, chronic damage to the gut from recurrent diarrheal illness and whether that's been modified by introduction of the rotavirus vaccine.
The rotavirus itself causes short-term damage to the gut. It takes about a week for, so basically when you have a rotavirus infection, what happens is that you see a blunting of the villi because rotavirus mainly infects the cells at the tips of the villi. So they become shorter, but within a week or so, it comes back to normal. You see much more damage with bacterial pathogens than you see with viral pathogens. Is there, but does it mean that if you have 5 rotavirus infections, that's equal to 1 Shigella? We actually don't know that. All we know is that kids in developing countries, the communities that I work with, an average child has 4 putative pathogens in their gut at any given time without any symptoms. And they have levels of inflammation that are higher than you would expect to see in a patient with inflammatory bowel disease.
So the question is around messaging of the fact that despite seemingly lower efficacy of the vaccine, there's actually a greater public health impact in places like India, Bangladesh.
So this is where working with modelers has been incredibly useful because people like numbers. So the 2 kinds of numbers we used, one was a costing study actually done by a student from Tufts in the early 2000s, where we were able to show that for the populations we were studying, about 5% of the annual income of a household would be used up on a 3-day hospitalization for a child. That's really powerful. And the second part of it was even with current coverage, even with low so called efficacy of the vaccine, these are the cases we are preventing. These are the deaths we are preventing.
For our online audience, the question was about the relative efficacy of poliovirus vaccine versus rotavirus vaccine, but also how the microbiome in different locations of the world may affect that.
So polio is actually a better vaccine than rotavirus. So if you co-administer the polio and rotavirus vaccines, the polio will replicate first, followed by rotavirus replication at other times. The way polio wound up being eradicated, or not eradicated, but at least excluded from regions and countries with just an oral vaccine, was to give many, 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 many more doses of polio vaccine. So it's been estimated that children, by the time they reach the age of 5, in some parts of India had received about 45 doses of polio vaccine. So it was just because you didn't know which child had been immunized or not. So you went into the population every month and gave every child that you could find polio vaccine. So it, yeah, with rotavirus, we don't have the luxury of the resources that polio has had to be able to even try to do anything similar. Fortunately for us, polio is a disease that can affect you if you are not immunized at any time in your life. With rotavirus, there is so much rotavirus around that over time, exposures will mean that the older you get, the less your chances of severe rotavirus gastroenteritis.
One final question and then. So the question is how vaccine hesitancy has changed in India over time.
In India, we're finding that the middle class is becoming more like the middle class in the rest of the world. So there is increasing vaccine hesitancy in people who have these notions of uh, excluding impurities from their bodies. So no antigens that need to be particularly injected. The oral vaccines have less resistance than the injected vaccines do. So it is not a humongous problem like it is here, but it's increasing.
All right, so I think Dr. Kang, as being very busy, has a call after this, and I want to make sure that we end on time. What I want to first do is to just note one, this incredible story, and it's both an incredibly unique success story, I think, and at the same time, it's a paradigmatic story of what's faced in global health, right? That we have so many innovations that, I mean, I look at TB, we've had treatments that can treat most people with most forms of TB that are highly efficacious for 50 years, and they don't get there. And you know, we still see 1.5 million deaths a year from TB. And so there are many of these hurdles that I think you systematically, along with obviously a huge collection of people, really navigated to make this successful. So this was an amazing story. Thank you so much for coming to our community. If we could give one more round of applause. And so I'm just going to remind the invited faculty to head over to lunch after this, and we'll see you there. Thanks so much. Our next seminar will be April 17th, and so thank you to everyone online. I will pass the online questions that came in later to Professor Kang to see if she can answer them. Thank you. Always stressful tomorrow.